the interest of time, we'll get started. Welcome to the August 25th, 2022 Standard of Care Ad Hoc Committee meeting of the California State Board of Pharmacy. My name is Sang-Oh, chairperson of the committee. Before we convene, I would like to remind everyone present that the board is a consumer protection agency charged with administering and enforcing pharmacy law. Where protection of the public is inconsistent with other interests sought to be promoted, the protection of the public shall be paramount. This meeting is being conducted consistent with the provisions of Government Code Section 11133. Participants watching the webcast will only be able to observe the meeting. Anyone interested in participating in the meeting must join the WebEx meeting. Information and instructions are posted on our website. As I facilitate this meeting, I will announce we were accepting public comment. I have advised the meeting moderator to allow 3 minutes to each individual providing comments. This approach is necessary to facilitate this meeting and ensure the committee has the opportunity to complete its necessary business. I would like to ask staff moderating the meeting to provide general instructions to members of the public participating via WebEx. Moderator?
This is the moderator. When the committee requests public comment, we will open the Q&A feature of WebEx. We will also display the instructions on the screen each time and verbally go through them. So you click on the question mark that is inside of a square, typically located bottom right corner of your WebEx screen. And in the text field that appears, you type in comment or I would like to make a comment, and you send it to all panelists. And then click the unmute me when prompted. If you prefer, you can raise your hand by clicking on or hovering your cursor mouse over your name, and the outline of a hand will appear next to your name. You click on that and it raises your hand. If you're calling in, the way you can raise your hand is by pressing *3 from your phone. Thank you. Back to you.
Thank you. Our member Thibault is trying to join as well, and I see Indira joined. So thank you, everyone. I'd like to take a roll call to establish a quorum. As I call your name, please remember the opening line before speaking. Maria Serpa.
Present.
Thank you, Maria. Renee Barker.
Licensee member present.
Thank you, Renee. Indira Cameron Banks.
Public member present.
Thank you, Indira. Jesse Crowley.
Present.
Thank you, Jesse. And Nicole Thibault. I see her name on there. Nicole, are you connected already?
Yes, I'm just trying to get my video connected, but I'm on. I can hear and see you all.
Okay. Nicole is here and I am here. A quorum has been established, members. As we begin, I'd like to thank you, all of you, or thank you for all your time and commitment to evaluation of this issue. This issue may appear on its face to be simple, however, it is quite complex. As you can see from the agenda, we're taking a pause and contemplating some policy questions as one request to present information was received, and we felt the need to gather some additional avenues of receiving info, such as surveys necessary. So we'll be discussing today about the survey before we continue on pondering those policy questions. We'll get back on those policy questions in subsequent meetings. I ask everyone participating today to be respectful of the work before the committee today. We encourage participation by members of the public throughout our meeting at appropriate times. The committee respectfully requests that when comments are provided, they're done so in a professional manner consistent with how the committee conducts its business. I will now open the meeting for public comments for items not on the agenda. I would like to remind members of the public that you're not required to identify yourself, but may do so. I would also like to remind everyone that the committee cannot take action on these items except to decide whether to place an item on a future agenda. Members, following public comments for this agenda item, I will ask members to comment on what, if any, items should be placed on a future agenda. As a reminder, this agenda item is not intended to be a discussion, rather an opportunity for members of the committee and members of the public to request consideration of an item for future placement on an agenda, at which time discussion may occur. Moderator, please open the line for public comment.
The Q&A is now open. The instructions are on the screen for your reference. If you would like to participate, click on that question mark inside of a square, typically located bottom right corner of your WebEx screen. And then in the text field that appears, type comment or I would like to make a comment, and make sure that goes out to all panelists and click send. When prompted, click the unmute me button. If you prefer, you can raise your hand by hovering the cursor, the mouse, over your name, and an outline of a hand will appear. Click on that to raise your hand. For those who are calling in audio only, you can raise your hand by pressing *3 from your phone. At this time, I see no request for public comment. Would you like me to close the Q&A feature?
Yes, please. Thank you, Elizabeth.
Thank you.
Okay, so moving on to the next agenda item 3, approval of June 22nd, 2022 meeting minutes. Included in attachment 1 of meeting materials is draft minutes from the committee's June 22nd, 2022 meeting. As we begin, do you have any questions or comments on the draft minutes? As part of your comments, I would also entertain a motion if you believe such action is appropriate. Members? Just feel free to speak up or just raise your hand, whichever you prefer. No comments? Anyone want to make a motion?
This is Maria. I move to accept the minutes as written.
Thank you, Maria. Any second for Maria's motion? And just a reminder, you don't have to be present at the meeting to make a motion or second the for minutes approval per our council from like last meeting. So
Hi, Sung. This is Jesse. I second.
thank you, Jesse. Maria motions, Jesse seconds. I hear no comments, so we'll move to public comments.
This is the moderator. The Q&A is now open. Instructions are on the screen. Click on that question mark. Send comment to all panelists, or you can raise your hand by hovering the cursor over your name and clicking on the hand outline or pressing *3 if you're calling in. No requests have been submitted. Would you like me to close the Q&A feature?
Yes, please. Thank you, moderator. With the motion and second and public comment, we'll call for vote. Maria, how do you vote?
Yes.
Thank you. Renee, how do you vote? Thank you, Renee. Indira, how do you vote?
Yes.
Thank you, Indira. Jesse, how do you vote?
Yes.
Thank you. Nicole, how do you vote? Thank you, Nicole. And I vote yes, the motion passes. Moving on to the next agenda item. Agenda item 4, moderator, if you could just make sure our presenters are all queued up and ready to go. Presentation on improving patient outcomes through a standard of care model, a collaboration with payers, providers, and pharmacists. Presenters include Dr. Stephen Chen, PharmD, Dr. Richard Dang, Dr. Michael Hochman or Hochman. Please correct my pronunciation, and you can correct me during your presentation. Dr. Michael Hochman and Dr. Alex Kang. Members, following our last meeting, staff received a request to allow an opportunity to present before the Committee on Patient Safety and Health Outcomes. As the chair of the committee, I approve the request for the presentation to be provided today. As we proceed, members, if agreeable, I recommend that we save questions until the end of the presentation. We'll have ample time to discuss all the questions to each of the presenters. Following member comments, we'll open for public comment unless there are questions or concerns with this approach. I'd like to welcome the presenters again, Dr. Chan, Dr. Dang, Dr. Hochman, and Dr. Kang. Please, moderator and Debbie, if you could make sure the presenters are ready to go, and the floor is all yours, presenters. I believe we have 4 presenters, so quite a presentation. Thank you, everyone. Thank you for joining us.
Thank you, President O. This is Richard Dang. Thank you for the opportunity to present with us today. We're trying to verify to make sure our entire panel is on, and I believe that Dr. Chen and Dr. King are on, and we're trying to get Dr. Hochman on as well, but he should be on by the time we get to a section of the presentation. So we shouldn't be able, so we can proceed without any delays. But thank you all, committee members, for having us today. We'll be presenting on improving patient safety and outcomes through a standard of care model, collaboration with payers, providers, and pharmacists. Next slide, please. Just by way of introduction, I've spoken before the committee before. My name is Dr. Richard Dang, president of the California Pharmacists Association and faculty at the USC School of Pharmacy. We're also joined today by Dr. Stephen Chen, Associate Dean of Clinical Affairs at the USC School of Pharmacy, Dr. Michael Hochman, who's a physician and CEO of Healthcare in Action, and Dr. Alex Kang, who is the Director of Clinical Pharmacy with LA Care Health Plan. Next slide, please. So just kind of frame the conversation for today, our aim is to provide the committee with a summary of evidence and real-world application in California on how pharmacists who are enabled to practice at the top of their licensure are able to become an added layer of patient safety and protection while improving health outcomes. So up to this point, we've been talking about standard of care in a very theoretical way, and we really wanted to provide the committee with real-world examples of how standard of care could be applied in a variety of different practice settings. So what we're going to be talking about is looking at the big picture overview, looking at some evidence, discussing the California RightsMed Collaborative, which is a really exciting effort that we have at USC with our community pharmacist partners. We'll be having Dr. Hochman present on his physician experience working with pharmacists in collaboration, and also having Dr. Kang talking about the health plan perspective and some of the benefits that they've seen from working with pharmacists in this quasi-standard of care model. So some questions to run on for today is what critical barriers does standard of care help us remove that currently limits the impact of pharmacists, that limits the impact that pharmacists can have on patient safety and outcomes, and also what value the standard of care add to health plans, payers, and physicians. So next slide, please. So I'll just begin with a really quick big picture overview, specifically how standard of care fits into the business and professions code in our state. Next slide. At our previous committee meeting, the committee discussed whether standard of care would fit in with certain practice settings, whether it's community pharmacy, chain or retail independent, AmCare, hospitals, et cetera. And I really wanted to focus in and just highlight the impact that standard of care can have in a community pharmacy setting, especially on equity and access. And this point is really highlighted by a recent paper published in the Journal of the American Pharmacists Association last month, where they looked at the number of pharmacies that are available nationwide, and they mapped it geographically to analyze the access that patients have to pharmacies. And ultimately, what they found was that 61% of the pharmacies nationwide are chain pharmacies, and about 38% are regional or independent pharmacies, with the remaining kind of 0.4% being government pharmacies. The point that I really want to hone in on using that data is looking at nationwide. They found that in metropolitan areas, 62.8% of pharmacies were chains. And in rural areas, 76.5% of pharmacies were franchises or independent pharmacy. So I bring this up because if the committee decides that it would be more feasible to restrict standard of care to certain areas, I would like to highlight that it does introduce a great level of inequity for our patients. If standard of care were to be restricted to not allow independent pharmacists to provide these services, we can see that we will be detrimental to the rural areas and vice versa for chain pharmacists in the metropolitan area. So the discussion of community pharmacies, I think, really needs to be looked at much more closely, because if we are restricting standard of care in certain practice settings, again, it would severely hamper equity and access for our patients. And when next slide, please. And when we look at that data specifically, this is the map that shows the level of access that certain areas can have. And California was actually pointed out as one of the states that has the highest level of pharmacy deserts, specifically in rural counties. In California, 43% of counties had low pharmacy densities, and those were often rural areas and often areas that relied on independent pharmacy locations. So again, we really urge the committee to be careful in its decision on which settings you might restrict standard of care, because that could potentially introduce some concerns with equity and access to the patient population and affect patient safety and outcomes in the state of California. Next slide, please. And so I would just like to emphasize that I believe that community pharmacies are suited for the provision of clinical pharmacy and health services, and especially independent pharmacies are a crucial access point for equitable access to care. So yeah, I already mentioned that if we limit where standard of care is applied, I would consider that a step backwards for protecting the consumers within California. Next slide, please. You're all aware of the business and profession codes that we have here that regulate the profession of pharmacy. So we have a number of different articles, 25 articles within the chapter affecting the profession of pharmacy and how it's practiced. And specifically what I want to urge the committee to hone in on is on Article 3, which has to do with the scope of practice and exemptions, which is where the conversation on standard of care should be revolving. So we have a whole lot of different articles and codes that currently exist, and it can get really confusing and messy when we try to look at all of these codes in the lens of standard of care. So honing in on Article 3, next slide, we can see some of the stuff didn't translate on this PDF here. But when we look at all the things within Article 3, we see codes that regulate dispensing, regulate compounding, regulate various clinical services under scope of practice. We also have regulations on licenses, licensees, on personnel and staffing, and payment and reimbursement. These are all bubbles within the profession that affect how we practice and that are all regulated under the parameters of the business and profession codes and the Board of Pharmacy regulations. And for the lens of standard of care, we should really be honing in on Business Profession Code 4052, which affects the scope of practice relevant to the provision of clinical and health services. Next slide, please. So the code that we currently have under 4052 of what pharmacists are quote unquote currently allowed to do, we have a lot of different sections. And when you copy and paste those codes into a Word document, we have 34 pages of close to 30,000 words that dictate what a pharmacist can and cannot do for specific disease states and specific clinical services. And when you compare that to other health professions like NPs, PAs, social workers, et cetera, on average, these other health professions, their scope of practice codes total up to about 5 to 7 pages for no more than 5,000 words. So you can see that moving towards a standard of care model, we can greatly simplify the scope of practice codes in terms of length and complexity and have it be on par with other equivalent healthcare providers. Next slide, please. And I'll wrap by saying, I also do want to recognize that we can't have the conversation on standard of care without also having the conversation on personnel and staffing and payment and reimbursement. And so as the committee evaluates how feasible it is to have standard of care, we can definitely have that conversation as far as what settings and what staffing levels and what staffing models it would be safe and appropriate to provide these services. And in my image here, I did address some previous legislative efforts that have gone on over the last few years to address personnel and staffing with the ratios that we have with the No Pharmacists Left Behind law and the ban on quotas and metrics. And then with payment and reimbursement, we have AB 1114 with Medi-Cal paying for certain services. And then that's also why we have Dr. Kang here talk about the health plan perspective to provide some perspectives on the payment piece. So all these elements have to be discussed when we think about standard of care, but I would encourage the committee to really focus in again on 4052, how we can simplify those codes of regulation to allow for the broad practice and provision of various clinical services within the parameters that are set by the Board of Pharmacy that help protect consumers and to allow pharmacists to provide these in a safe environment. Next slide, please. So now I'll pass it over to Dr. Steve Chen to talk about the evidence and the efforts that they have with the CRMC. Steve?
Thanks, Richard. And I really liked how you highlighted that there is a need to simplify, but at the same time, I want to assure you that there's no compromise in safety and quality, which is what we'll share in this example. Next slide, please. So a little bit of background, and please forgive me, members who have heard some of this before. I'm not repeating what I shared last October, trying to highlight parts that are relevant to this discussion. I think the bottom line is we have an ongoing epidemic that we haven't resolved yet, which is suboptimal use of medications, which costs us in terms of lives, dollars, big dollars, 16% of all healthcare costs, and accounting for 3/4 of all hospital readmissions. This is something that we really need to resolve in a way that is efficient and makes maximum use of the scope of people with expertise. Next slide, please. And what I'm referring to here in the context of medication management is comprehensive medication management. And to be clear, I guess you can call it the value-based version of MTM. It's all about making sure the right med is chosen for a given patient's diagnosis, the right dose is given, not so low it doesn't do anything, not so high it causes toxicity, that it's safe given other comorbidities and other medications, that they can use these devices appropriately and correctly, that they can afford their medications, and that all of this is wrapped up into an outcomes-driven objective. Basically, follow-up is provided, collaboration with physicians and other providers is a must until the patients reach treatment goal. Next slide, please. And in terms of evidence, there's plenty. We wouldn't have enough time to talk about it, but all of these organizations you see represented here are not pharmacy-based organizations. There are other healthcare entities that are the primary owner of these organizations, and all of them have overwhelming evidence of the importance of pharmacists practicing at top of licensure to achieve the outcomes that have been well documented in the literature. Next slide, please. I'm going to share a couple of examples here in California that I think speak to this the standard of care focus that we have today. One is the Barbershop-based hypertension program in Black barbershops in Los Angeles, led by the late Dr. Ron Victor. Had the honor of helping him set this up, but unfortunately I couldn't work with him on the project. Next slide, please. So this study involved pharmacists actually going into barbershops and managing hypertension in these barbershops. And that first line is from Dr. Victor himself, right? He testified in front of the legislature about the importance of this bill that we had originally proposed to allow pharmacists to do this. And he said, look, in my own independent analysis, there are 40 to 50 studies, mostly government funded, that demonstrate the value and effectiveness of pharmacists managing hypertension. And in his opinion, if we don't allow pharmacists to do this, it's wasting taxpayer dollars because the evidence is so overwhelming. As I mentioned before, as you saw from the previous slide, there's plenty of CDC literature that confirms the value of pharmacists in this space. They're only the first 5 lines of medications for hypertension are cheap, generic, widely available. There's really no reason why we can't achieve better blood pressure control than we have now, which is under 50% as a whole. We can get this done quickly if done with a reasonable level of scope of practice. Pharmacists can achieve blood pressure control for any patient within 45 to 90 days. And this is important. I'll revisit this later on in the context of the standard of care law that we're talking about here. Really can be provided in any setting, very successfully in a barbershop. and of course, in this case, we're talking about hypertension, but as you know, patients often don't only have hypertension. They also have out of control diabetes, dyslipidemia, heart disease, heart failure, and so on. Next slide, please. So in this program in particular, you had pharmacists going at least monthly to barbershops to manage hypertension, more like every 2 weeks in the beginning to very aggressively get patients to goal. It took about 6-7 visits on average. They would check blood pressure, modify drug therapies. They had a collaborative practice agreement, but keep in mind the reason why they were able to get this is because this is Dr. Ron Victor, the guy who actually writes the clinical hypertension textbook, right? So when we went out there and promoted this to other primary care physicians, everyone signed on. I mean, you have the best in the nation, if not the world, that was overseeing this program. So that was easy. But that's not so easy outside of this context, which is, again, why I think standard of care is so important. Electrolytes were monitored using the iStat point of care device. Physicians were always informed of what was going on. This is really important. This will continue after standard of care, meaning physicians got progress notes within the day of care being delivered. And if there are any concerns, they would contact the pharmacist. And I've done this work for 25 years. Physicians don't worry about what pharmacists are doing because we have a very strong hold on drug therapy, monitoring, dosing, et cetera. And then kind of the bonus of this project is one of our alum owns a pharmacy in South Central Los Angeles. They deliver medications to the barbershop at cost, so huge perk. Next slide, please. The outcomes speak for themselves. Back then, the hypertension goal was 140/90 for just about everybody. You saw 90% control of hypertension in the intervention group versus 32% usual care. And before you think, hey, it's because they didn't have insurance, other barriers, 83% of participants had insurance. 1 in 4 patients were Kaiser patients, the same as the ratio across the state. So this was a broad variety of patients that we're talking about here, where the intervention was overwhelmingly positive, and largely because of the ability for pharmacists to identify the shortfall in treatment, make treatment changes, make treatment adjustments, order tests, et cetera. That was key, and that is what got it done so quickly and efficiently. Next slide, please. We've done some work as a part of a Center for Medicare and Medicaid Innovation program here in Los Angeles and Orange County. We received this $12 million grant back in 2012, where we had 10 clinical pharmacy teams integrated into one of the largest private safety providers in the nation. We included a telehealth component, and we basically had quadruple aim outcomes in the study, serving largely Latino and Black patients. Next slide, please. And no time to go through the data, but bottom line is you saw an absolute difference of 10% in all healthcare quality measures that we looked at, particularly in the metabolic syndrome areas, diabetes, hypertension, dyslipidemia. We saw lower healthcare costs for patients that had previous readmissions, overwhelming physician acceptance and buy-in, which Dr. Michael Hawken will speak to, because at the time, he was medical director for innovation at the site where this study took place. We had very high patient satisfaction. Again, Dr. Hawken will speak to that. Next slide, please. And when this program was over, oh, sorry, before I get that, one of the important things I want to highlight is what did we actually do for these patients? You can see that among 6,000 patients enrolled, we identified over 67,000 drug-related problems. These are not small problems, 11.5 per patient. It's got to scare you a little bit. The most predominant problem that we identified is that red slice of the pie, appropriateness and effectiveness of drug therapy. That means a better drug based on evidence could have been used. Dose was not quite right, or actually in many cases, an indication was there for drug therapy and no drug therapy was given. On top of that, another 20%, if you look on the bottom, were medication safety issues. So actual adverse drug events or potential adverse drug events. So all in all, over half of the interventions made that we're talking about here had to do with safety and quality of drug therapy. So pretty serious issues that we were able to identify and fix. Next slide, please. So as we evolved into the next phase of what we're going to do next after the study, we were faced with the issue of, look, a lot of the patients in the community, as Dr. Dang just shared, have a really difficult time accessing healthcare. And even when they do, if you look in the right panel, sometimes they're getting advice that doesn't work for them based on their culture, their community, their access, et cetera. Next slide, please. So we went ahead and leveraged what Richard shared, which is, we have this network, you can go to the next slide, please, of community pharmacies all across the nation, 4 times more pharmacies than Starbucks, if you can believe that. Although it's not showing in that red box for some reason, the study that looked at how often Medicaid patients show up in community pharmacies showed that they typically show up 2 to 3 times a month. So it's a lot of face time, a lot of access, an untapped resource in the healthcare system. So we decided, let's figure out how to partner with health plans, clinics, and pharmacies to deliver comprehensive medication management in the neighborhoods where patients live, especially for underserved populations. Next slide, please. And so we did that. We were able to partner with LA Care Health Plan, which Dr. King represents and leads, and Inland Empire Health Plan, and a few others. Now, a total of 4 health plans that cover just over 8 million lives. And this is the sort of the word picture of how it works. The health plans identify the high-risk patients they want to enroll. They stratify patients from high to low risk. They send those high-risk patients to the pharmacies that we train through the California Right Meds Collaborative. We conduct rigorous continuous quality improvement, and we ensure the outcomes are delivered that result in a value-based payment. Next slide, please. These are just an example of the plans and the other partners that we have in this collaborative so far. Next slide, please. We have some international partners. And the training is rigorous, right? So we have live learning sessions all day where we share best practices at providing these services, and we share tools, resources, et cetera. We have training specific to the level of ability that the learners have coming to these sessions. And then in between these learning sessions, we have webinars, at least once a month, often twice a month, that cover everything from disease states, motivational interviewing, patient engagement, cultural competency, as well as sessions to go over quality improvement. Next slide, please. And these are sort of the keys to making it work, right? We vet pharmacies carefully, which is in partnership with health plans to make sure that we have the right pharmacies in place geographically and in terms of capabilities. We train pharmacy technicians to provide clinical support. We have a documentation platform that works across all pharmacies. We have a grant from the CDC that's helped us get this started, the value-based payment I mentioned before, and a very rigorous continuous quality improvement process, which is really important to make sure that patients get better, the plans get what they're paying for, and the outcomes are achieved by the pharmacists. Next slide, please. Just a quick example of what the value-based payment looks like. We basically wanted to cover the cost of a pharmacist and a technician and about 10% indirect to the pharmacy. Next slide, please. An example, the quality improvement report card, pharmacies are de-identified, color-coded in terms of how well they're doing. We use this very effectively to guide training, to provide coaching to teams that are struggling. And frankly, I think the plans like this, when there are teams that clearly are not going to make it, we let them go. And we've done that a few times. We've had to. Next slide, please. We'll skip this one. Sorry. There's a lot of integration with the health plans in terms of what we do and in partnership with them, but I won't go into the details here. Quick example of an impact. This is the work with LA Care Health Plan. Currently, we're up to about 15 pharmacies that are spread throughout the county, a whole host of federally qualified health centers that are paired with these pharmacies. Next slide, please. And for this pilot that we ran, LA Care decided that they wanted to test this program in out-of-control diabetes patients, A1C above 9%. However, to get the full payment for this for these patients, the pharmacies had to get A1C at least less than 8, high blood pressure at least less than 140/90, often less than 130/80 in most cases, and then statin on board if clinically appropriate, which is in most cases. Next slide, please. So we got about just under 500 members represented in what you're about to see. Just about half are, a little over half, are in Antelope Valley and South LA areas where it's very difficult to get easy access to healthcare. Over a quarter are self-identified as Black. Next slide, please. And you can see the results here. Average A1C dropped from baseline 3.3 points, systolic blood pressure reduction of 34 points, and statin utilization up around 90% from a baseline of 42%. So it works. The program works very well, again, because of a lot of different components, and key is the partnership with health plans. Next slide, please. So what's next is we're expanding the number of pharmacies and patients involved, growing the number of health plan partnerships. We have a very rigorous analysis of the outcomes being conducted by our health economics team here at USC. We're adding a psychiatric component because many of these patients have comorbid mental health. And Covered California has this listed as a vendor, so we're hoping to expand into that space, into those health plans. Next slide, please. So a bottom line is there's something for everybody when pharmacists can practice at top of licensure in a manner where they're reasonably compensated and really in a manner that's value-based. What I will say here is I've practiced for 25 years, integrated into health systems with full scope of practice, CPAs and all that. And I can tell you that the difference between not being able to practice under a collaborative practice agreement versus with one is that we're able to be much more efficient. And most importantly, I think, is to keep the patient engaged. And let me give you an example of that, right? I think I shared it in the beginning of the Barbershop program, as well as my work in integrated clinics. We typically get an uncontrolled hypertension patient to goal within 45 to 90 days, right? It's really easy, 6-7 visits. In our collaborative, it's taken longer, more like 6 months, sometimes a little bit longer, because even if we identify a change in drug therapy that's necessary, just a modification of dose, whatever it might be, we're having to go and chase down the physician who's very busy. And he probably wants us to do it. He actually does want us to do it. It's just the difficulty in getting back and letting us know is a lag. And it frustrates patients, right? Because they want to get better. They're engaged. We have them excited. And they're just not getting the rapid turnaround of care that they should expect. That's been a frustration, and it's slowed down our progress. And I can see standard of care helping to remedy that. And very importantly, in the end of the day, with all these stakeholders on board, holding pharmacists accountable, patient outcomes accountable, and maintaining it all through an incentive-based payment, there's no compromise in terms of safety and quality of care. So with that, I'm going to hand it off to Dr. Hockman. Thank you.
Well, thanks very much, Steve, and thanks for the opportunity to speak with you all today. My name is Michael Hockman. I'm a primary care doctor, an internist, and I'm going to give the perspective of a primary care clinician working and the benefits that advanced practice clinical pharmacy can have. You know, I'll start by saying I did my medical training on the East Coast, and I always liked pharmacists. They saved me many times when I wrote the wrong thing in the retail setting. But I had a very traditional view of pharmacists, maybe as many of the lay public do. And when I first came to California, I worked at LA County USC Medical Center, and we were doing a patient-centered medical home innovation with a safety net population. Someone suggested I reached out to Steve because we were having so many problems with medication. And Steve placed a pharmacist in our clinic, and just the impact it had right away on the care for the patients and their experience was very dramatic. And I remember at the time, the dean, Pete Vanderveen at USC, said something to me. He said, pharmacists are the most well-trained yet underutilized healthcare professionals. And I have found this to be, over the next 10 years since he said that to me, extremely true. You know, we have a problem in healthcare with not using people at the top of their license, using RNs to do medical assistant work, using LVNs to be, to do things that they do not, we can have a lower scope person do. And I have found this to be particularly true with clinical pharmacists. And as everybody here knows, they go through 4 years of training and many of them residencies and have just tremendous, you have to get very good grades to get into pharmacy school. So I think there's a real opportunity to use them more effectively. If I can go to the next slide, please. Um, I just wanted to describe, this slide's a bit tongue in cheek, but how practice is different for me when I have a advanced practice clinical pharmacist with me. So say I have a patient with a chronic condition like diabetes, high blood pressure, heart failure, lung disease, whatever it may be. I'm going to use diabetes as an example. They might come to me and their hemoglobin A1C is 14, meaning their diabetes is very poorly controlled. And I will start them on a medication like metformin, and I'll have them come back a week later and adjust that medication. And then we'll have them come back 2 weeks later, and maybe they'll call me with some blood sugars. And at some point, we may or may not start them on insulin. And probably along the way, I'll get distracted by the shoulder pain and the depression, and they end up in the hospital. And 3 months later, very often what's happened is we have not actually gotten to the bottom of the issue. The patient still has not great controlled diabetes, and we've sort of lost focus on other issues. I met Steve first at LA County USC. Then I went over to Ultimate. I was the medical director for innovation, and just coincidentally, there was the new CMMI, the Medicare Innovation Challenge Grant, where we had the opportunity to put clinical pharmacists in 12 clinics there. And the way it worked for me in that setting is that same patient with the poorly controlled diabetes came to me. I would walk them over to the clinical pharmacist, who would, under a collaborative practice agreement, evidence-based collaborative practice agreement that our organization had approved, that I as the physician had approved, that the chief medical officer of our organization had approved, all on the same page, would do the exact same things that I would. And that would really free me up to do the doctor things, the calling the specialist, the following up the patients in the emergency department. And what I found is that more often than not, that 3 months later, the patient returns to me and their A1C was under much better control. The pharmacist had been able to get to the bottom of it. How did they do it? Well, in many cases, they did a crazy thing. They called the patient. You know, we doctors love to have everybody come in every week. The clinical pharmacists don't do that. they I think have a more patient centric approach, and they followed the protocols, and they didn't get distracted by all the other things, and they have a little more time than the 8 minutes, which is about what a primary care clinician has in a typical safety net setting to see a patient. Next slide, please. So Steve showed this slide. It's all the various different things. As you can see, I initially thought it was going to be all safety issues. Maybe we doctors started medications that interacted and the pharmacist would identify that. But they found all sorts of things. They found that we were not using the most evidence-based treatments. I remember right around the time the cholesterol guidelines changed, and Steve's team did a really good job of converting a lot of the patients to statin medications, which are much more effective than the fibrates and niacin that many of us had initially, learned to use. So really, as you can see, a broad mix of different things that an advanced practice pharmacist does. Next slide, please. So, again, here's the data. We saw some very significant improvements in blood pressure control and hemoglobin A1C control, lung disease control. The long and short of it is that clinical pharmacists didn't do just as good as we doctors did. They actually did better. I believe it was 11% better blood pressure control if you had a clinical pharmacist, 9% better diabetes control. And that was, again, as I mentioned in Ultimate, we did this at 12 clinic sites and we picked 12 control groups. And, again, it did, not only was the disease control better, but it freed me up as the primary care clinician to manage all the other things in my scope of practice that needed to get done. Next slide, please. So, in healthcare, you may have heard the term of the quadruple aim, the patient experience, the cost of care, the quality of care, and the provider experience. And at the end of this 3-year demonstration, I realized that this is one of the very few things in healthcare that truly hit the quadruple aim. First, let's start with patient experience. On the 1 to 10 scale, we did the, would you recommend this service to your friend, your neighbor? The average was 9.6. And for those of you who know Ultimed, Costello de la Rocha is the CEO there. Great guy, amazing leader, done so many things in his career. One of the first times I ever met him, I got a notice to go up to his office, and I was really nervous. What's this going to be about? What did I do? And he said, Mike, I hear you're in charge of these pharmacists, and I see that they have a 9.6 score, and our doctors are only about 8.7. What's the difference here? Why are they doing such a good job? Why do patients like it so much? And, at the time I was nervous, didn't have a great answer for him. I said, USC is a great program. But I think the real reason is that, and then this is what patients told me over and over, they like the fact that the pharmacist could really get to the bottom of the issue in a way that we couldn't in that 8-minute visit. So the pharmacy team, as I mentioned, would call the patient, would remind them, would send the sugars, they'd go back and forth by email. With me, the only way they can interact is in that 8-minute in-person visit, and it just doesn't get done in the same way. So patients really appreciated that. I talked about the better outcomes, the blood pressure control, the A1C control, better than the standard of care. Cost of care, actually, I'm going to come back to that one, and I'm going to say the staff experience. So, as I mentioned, there were 12 clinic sites where we implemented this intervention. Very quickly, some of the other doctors at Ultimed started referring patients from the control sites to the intervention sites, which was a bad idea for the research study, but they wanted their patient to get the best care. There were even some who tried to switch their clinic sites to have a clinical pharmacist supporting them. When the grant ended, there was an uproar, and there was a big push, and Ultimed, to their credit, ended up providing some resources to sustain the program in an intermediate capacity. So my point there is that this was a real staff pleaser too. And then on the cost side, there's very, very few things that we can do in healthcare that truly bends the cost curve. We have some data from this and other demonstrations that we could avoid some avoidable emergency room and hospital visits. Can I give you a randomized trial showing that this lowers the cost of healthcare? No, but what I can tell you definitively is that this is a high value service. And we talked about it like this at Ultimed. The budget at the time was about $300 million a year. And we sat around the table and we said, with this fixed budget, we believe that at least a couple of those million should be supporting clinical pharmacists. It's a high value thing, high bang for the buck. We can get really good care for our patients with that investment. And that's exactly what Ultimed ended up doing. It's much more challenging in a fee-for-service setting where there's not direct reimbursement. So it only works in settings like the VA and Kaiser. And I think what the pitch here today in part is to create a pathway to do this into a broader setting in community environments, not just integrated delivery systems. Next slide, please. So that's basically it, the business case. I think everyone agrees this is a high value service. It is something very good for patients, patient experience, quality of care, providers, doctors. It's just a matter of how to integrate it in a way that can get reimbursed, and there's a clear business case to do so. Next slide. So I'll mention that I was at Ultimed for several years, and recently I moved over and started a new nonprofit called Healthcare in Action. I'll acknowledge the SCAN Health Plan, which is funding this. We're a group that's exclusively dedicated to patients experiencing homelessness. We have mobile vans. We care for patients. We do through the CalAIM program of contracts in Southern California with LA Care and Molina. And not surprisingly, one of our immediate first needs was pharmacy services. We use very complicated medications for patients who are homeless, psychiatric medications, long-acting injectables. substance use treatments, Sublocade for opioid abuse, Suboxone. And again, we have immediately reached out to clinical pharmacists. We found some community pharmacists in this case who are helping us ensure that we can get patients the medications point of care, again, really integrating it into the care team. And we're trying to do some of those advanced practice clinical pharmacy settings. What we'd really love to be able to do is to have a pharmacist go out to one of these encampments. There's one I can think of where there's a number of patients who are all HIV positive. There's now a long-acting injectable HIV medication where we could give them once a month injection. I think this is very ripe for a clinical pharmacist. Same thing with the mental health and substance use side. And I don't need to tell anybody in this call, we have a crisis right now with homelessness. And I think part of the challenge, one of the barriers is that we're not doing a good job of controlling these mental health, physical health, substance abuse conditions. And I really think that, as Pete Vanderveen said, a pharmacist would be a high value investment for addressing this problem for the unhoused population. I think that's my last slide. Yeah, I'll bump it over now to Alex.
Thank you, Dr. Hodgman. My name is Alex Kong. I'm the Director of Clinical Pharmacy at LA Care Health Plan. So just as a background, LA Care is the Medicaid plan for LA County. So we have 2.4 million people, and we're the largest public health plan in the United States because of that. And so when you think of LA County, when you think of Los Angeles, we know it's very diverse. We have everyone from every country in the world lives in LA, right? But probably minus, there is no language you cannot find in our county. And when you think of LA, a lot of people think of, oh, it's just a big city. But when you look at the whole county of LA, we have like dense city areas like downtown, South LA, East LA. But when you go up to the Antelope Valley, that's rural farmland. Is what you don't realize. That is literally open space where not many people live. And we have suburbs like the Valley, where Cerritos down north, more close to Orange County. So in a sense, LA County is geographically like the whole state of California. It condensed in one small area. And one of the issues that LA Care has is that we need to have services in areas where there just isn't enough providers, right? You go to South LA, you go to Antelope Valley, where it's very rural. There just isn't many providers that can see our patients. And so how CRMC got integrated into our program is very simple. One of the programs that we have in the pharmacy department, we go out to FQHCs, federally qualified health plans, and we talk to doctors and we train them on how to give their patient medication. So we went on training to teach them how to titrate insulin. And after the talk, we had a 1-hour training session, how to start the patient's insulin, how to do it correctly. Then one of the doctors came up to me and said, this is the best thing I've ever heard, and I wish I could do it, but I literally have 8 minutes to 10 minutes to talk to my patients. And unless I have 30 minutes, this is not possible. And so that really opened my eyes. So how can I, as a pharmacist, do something for our patients? We always talk about getting, health equity, getting where we need the care to where we have to get it to where it's needed. And when you think about our prescription volume, it's surprisingly half our prescriptions don't go to a chain pharmacy like a CVS or a Walgreens. They actually go to independent pharmacy. And an independent pharmacy is very important for our network for a very specific reason. The independent pharmacist speaks the language of our patients. I'm not just speaking of Spanish, right? I'm thinking of like Chinese, Korean, Vietnamese, and we have Hmong. We just have Armenian, and it's the affinity that the patient has with that pharmacist that just increases the trust and the interaction. So when in Dr. Chen's slide, he had that map of LA County. We have, for example, a pharmacy in South LA where we see majority of Black patients, and we have a Black pharmacist in that pharmacy that sees most of the patients. And because of that, we've seen increases in adherence for our diabetes medications. We have even in East LA where we have independent pharmacies, and you can't just blanket everyone who speaks Spanish as the same, right? Someone from Nicaragua is not the same as someone from Colombia, right? There has to be some understanding of the cultural differences even within that population. And what we're seeing is when we use independent pharmacies to send to increase health, we see a way better outcomes in the patient. So what CRMC does is what we practice is we train these pharmacists to see patients in areas where there's more help is needed, right? So Dr. Chen showed a decrease of 3%. 3% A1C. I know not everyone's a clinician here, but people who have a decrease of 3%, they are gonna go into the ER soon, and they are gonna have issues very, very soon if their diabetes is not under control. And for some of our independent pharmacies step up to see these patients and bring them under control and spend the time that some of these meetings they're not 8 minutes, they're up to an hour, right? To see patients, to help them with their medications. And it's not just like, we focus on diabetes, but it's not just diabetes. We're helping them with everything, especially if they're an LA Care member. We're making sure if they have homeless issues, if they have food insecurity, if they need appointments for other health needs. So we kind of have this all-encompassing care setting that our pharmacists help because of the reach that an independent pharmacist can do. And we as a we always talk about like, okay, hey, we want to get the care. We always want to do give health equity and to where it's needed, and we want to use our services to like to a diverse audience. The independent pharmacy and the pharmacist is the way to go. Not that the chain can't do it, and I'm sure as we expand upon our services, a CVS will jump on board, right? A Walgreens will hopefully jump on board. But as of right now, it's the independent pharmacist that has its outreach. So what the standard of care will do is make my life easier. As a health plan, we're willing to pay to get patients healthy. The problem is there's no vehicle. It's you can't throw money at a problem. You have to have a way to get that problem solved. And we see CRMC as that first step. And having the standard of care change to make it my life easy because the back and forth, because we don't have a standard of care that has to go forward to get a medication change. For example, a lot of my pharmacies, if they don't have a CPA agreement and a patient comes that the doctor doesn't have a CPA agreement with, they have to fax a recommendation, call for recommendation. They have to call maybe up to 10 times before someone's blood pressure or diabetes medication change. And that is a deliberate delay in care that cannot be accepted. So what my call to action for this committee is please help me address this standard of care so that I can help my patients. And I have the vessel in LA County, right, to help a huge population and the pharmacists that I'm using are so integrated into the community that they are making a difference now. We see the results. A1C decrease of 3%, blood pressure under control, we're getting our statin medication. And it's hard to qualify, right? Like in a sense, like how much, because we don't always talk about costs. But when you talk about the money we spent to the money we're saving, I'm going to use that saved money for other purposes within LA Care, right? Because not everyone, an ER visit is a $50,000 visit, right? Compared to me spending maybe a couple hundred on just pay a pharmacist to take care of a patient. So I see this as a win-win for everyone. Not am I increasing the care for all our members, I'm also increasing the small, pool of money that the state gives us to take care of our members. So that's what my call for action is. Help us help these patients out. And the way to do it is through these neighborhood independent pharmacies, because the pharmacist it is a cliche. The pharmacy is the easiest place where a person can get access to a healthcare professional. It's you don't need to wait. You don't need an appointment, right? You will stand in a line and you can talk to someone like that day within that hour, right, at a pharmacy. And I think that's so crucial in this time. And even during the COVID pandemic, our pharmacists, because they couldn't see people face to face, they called people constantly to get them on their meds. So the pharmacists are capable of so much more, and I just hope that you help us achieve that goal. Thank you.
We'll pass it back to Chairperson O. Thank you for the opportunity to present today.
Guys, I really appreciate your time. I have a lot of questions for you all, but I'm gonna let our members ask away. They can ask to the panel. They can jump in, or they can direct to each one of you specifically. So anyone who would like to just go first, raise your hand or just speak up. Members. No one has any questions. I'm going to ask all the questions because I have a lot. Okay. Oh, go ahead, Jesse.
Sorry, this is Nicole.
Go ahead,
Yeah,
Nicole.
it's okay. Thank you all so much for your presentation. That was super helpful. I was wondering if, we heard a lot of kind of some of the traditional ways that this can be used, high blood pressure, diabetes, these are fairly common. Could you all comment maybe on some of the more unique ways you're seeing this used? I heard us talk about the unhoused population. I think that's a really interesting one. What are, a couple other ways that you could foresee this being used that are a little maybe more novel?
Alex, could you start? Because I know LA Care has all sorts of initiatives targeting a variety of underrepresented minorities.
Yeah, so for us, we've actually had a pharmacy that was delivered to like the homeless population. It's kind of like what Dr. Hoffman's organization does, and so you know the pharmacies are in areas where there is a big homeless population, and there are members. They're members of LA Care, and for me to get them the care, it's not. To be fair, it's not going to be a CVS pharmacist that's going to go out there and deliver meds. It's not part of the corporate plan. It's going to be an independent pharmacy, right? That's a little more flexible and that could deliver meds. So I see the CRMC pharmacists doing this at a homeless camp or an encampment where they're living, right? So when I think you have to see the value of an independent pharmacy that's way more flexible, that has the language skills, and that has the willingness to learn about different diseases. And it's not just, and it's also mental health, right? We see a lot of mental health issues, and one of the ways we're expanding CRMC program in our things, we're working with the Department of Mental Health. We're going to partner with the Department of Mental Health on a program for that with our behavioral health partners in LA Care. We have the behavioral health department, and we're working with them to see their patients, which are many of them are have mental health issues and have need housing, and we're working with them to address their needs through CRMC. And the great part is we do have pharmacies all over the county, and LA County is such a big county, and I can't emphasize that enough about like how unless you've driven through Antelope Valley, for example, it's farmland. You might think you're in Kansas if you didn't know better. So the health disparity in LA County, we're not an urban or a city dense urban area where we have a pharmacy in every corner. Also, it's just how the medical care is spread out is not equitable. So that's one of the ways this CRMC program addresses it. But the issue, like I said, I'm having is that because I don't have the standard of care model around me, the training that I have to do for the farm, the paperwork, even the paperwork to sign off on something, this is a public meeting, but try getting something to LA Care legal. It's like, good luck. It's like it might be hard in the state because it just anything that lawyers touch, it just takes forever. So that's my frustration with not having the standard of care model in place, and that's why I'm hoping that this addresses so that I can expand the number of pharmacies, because as I expand, more care will be given, and I can expand to the homeless population. I can expand to mental health, and right now because this doesn't exist, the training and effort is so much that even getting up to 15 took a year, right? A year and a half, 2 years. But if this thing changes, I could probably increase tenfold within a year, because it's just going to be just a snap of a finger will do it. And that's why I'm here to advocate for this. So I'm part of a payer. We're willing to pay for this program to get people healthy. So let us pay and spend the money and get people healthy and under control, and and live their lives to the best of abilities. And that's what my hope is.
And Nicole, if I can comment really quickly, thank you, Alex. That's great. I was really excited that LA Care ventured out into the mental health population, starting with patients on antipsychotics, making sure that they're taking their meds correctly and getting monitored correctly. We put together a fantastic program that will take pharmacists in the community and primary care settings and instill them with key skills and techniques to evaluate patients, and it has to be done uniquely, right? When you're talking about adherence, and you know this because of your area, when you're talking about adherence and utilization of meds for mental health patients, it's a different approach as how you work with them. So we have a whole curriculum that'll empower these pharmacists to be able to do a very careful and thorough evaluation of these patients to ensure that their outcomes related to mental health and metabolic syndrome side effects are well managed. The other thing is Alex's program with LA Care also supports home visits. So we do have some of our pharmacists doing home visits for select patients, and it's very effective.
Thank you all. Part of the reason I was asking that question is because I'm just kind of wondering if this is something that can be set up quickly to respond to ongoing health and public safety issues. Like, for example, monkeypox has been, we're not seeing it being uptaken by a lot of the large organizations. I work for the Los Angeles LGBT Center. And since this is primarily affecting, men who have sex with men and members of the LGBT community, we are seeing the burden hitting smaller pharmacies and smaller clinics as opposed to being taken on by the larger institutions. So I'm kind of in my mind trying to think, is this something that could be set up quickly to respond to public health emergencies or other kind of things? I don't know what that looks like, but just kind of wondering what you all thought about that.
Yeah, Nicole, if I can add on, thanks for bringing that up as well. I think that's a really good example of something that we're experiencing in real time where standard of care is helping a little and can help so much more. At the first presentation I had with this committee, I talked about if we had standard of care, we could be much more nimble in responding to these public health emergencies. And one example, we were able to do that with monkeypox specifically, is when we look at vaccination scope of practice, that's basically, like I said, standard of care for vaccines, right? With the new law in 2020, pharmacists can administer and initiate any FDA approved and CDC vaccine. So when the monkeypox issue came up and the monkeypox vaccine became something that was needed, pharmacists would be able to right away say, yes, I want to volunteer and help. And in fact, that's happening in LA County where, their independent pharmacists, like you mentioned, are signing up and volunteering to help the larger organizations like LGBTQ Center and others that have taken on the initial burden. If it weren't for that standard of care for vaccines being in place, who knows how long it would have taken for an emergency waiver to be put in place and to get pharmacists engaged. When it came to COVID, it took months for that to happen. And arguably in a public health emergency, we don't have that time. So that's a really good example of how standard of care could allow our profession to be nimble by just saying, pharmacists can do any vaccine, as opposed to before when it was very specific. Pharmacists can only do flu vaccines. Pharmacists can only do flu and pneumococcal. Okay, they can only do routine. Now it's any vaccine. So whenever a new product comes to market, we can utilize it right away. And now we're looking to see, well, can we expand that standard care model to all therapeutics and not just focus on the subset of vaccines?
Thank you. That was a really great example. I appreciate it. Thank you all.
Thank you. Jesse, go ahead.
Thank you so much for the presentation. There's a lot of good information and I have a ton of questions, so thank you for your patience. First of all, I think these programs are amazing. They're very impressive, clearly show that pharmacists can really be part of addressing some of the gaps in healthcare and addressing some health inequities. I'm more curious to see some drug and patient safety outcomes, specifically in non-clinical settings and more in standard retail settings. I'll kind of go through the line in order of the presentation with some of the notes that I have. I thought the Barbershop article was really interesting. For me, the impression that I was left with was the importance of collaborating with trusted community members who aren't necessarily healthcare providers, but who have these trusted relationships with people who may be more hesitant to listen to a doctor or pharmacist recommendation. And I think it's great that pharmacists in the study were able to address and add on hypertensive medications in a way that physicians in a clinic didn't necessarily do. However, I do think that we have to consider that these pharmacists were specifically going into barbershops rather than patients coming to them, which may have made it a little bit more successful due to that community collaboration. So I would be interested to see that kind of the comparison of a controlled group more in a pharmacy setting versus barbershop. But I think it's important to keep programs like this up and running. And I think it's amazing that you were all able to put this together. I did have a question specifically about the USC CMMI program. I noticed that it said the study mentioned a reduction in physician burnout. Do you know if there was any measurement for pharmacist burnout? That's a topic that's been coming up so much in our Board of Pharmacy meetings. So I think it's important to kind of address that and see if there was any information about pharmacist well-being in this program.
So first of all, you're very astute that picked up what you did in the barbershop project. You're exactly right in that selling to patrons was all about the barber, that relationship. Fully agree with you. Would not have had any success without that. So that's point number one. The other is we recognize that as well. And in our programs based on community pharmacies, guess who the aligned, culturally competent person is in the pharmacy? It's usually not the pharmacist, usually the technician. And we find them to be golden in developing those relationships you're talking about that result in trust and confidence. And I think if you were to look at just pure outcome metrics, the average systolic blood pressure reduction in the barbershop project was 27 points. We're at about 34. So at least we're showing that we're able to do something similar in a community pharmacy. The one challenge that the barbershop project has been faced with is efficiency, right? On a good day, a pharmacist can see 6 patients. That's not a lot. You can see a lot more in a pharmacy. And so that's one of the drawbacks of the barbershop project is that we want to keep it going. The cost effectiveness model says that the impact is so good that it's worth it. But it's a tough investment to bite into for some people. So that's been one of their challenges. For the CMI program, I'm sorry, I lost your question again. Your question was on the CMMI grant, sorry.
Yeah, it was asking if there was any measures of pharmacist well-being in there. I know that it did mention an improvement in physician burnout, and since pharmacist well-being, along with many other healthcare professionals right now, of course, in a pandemic world, I was just curious if that was a measurement at all.
I think you're right in that if we were to do this project today, we would have measured it. Back then, we didn't. In a 3-year sprint, everyone was so excited. I can tell you that there was no burnout because we were just thrilled to have this opportunity. But we didn't measure it, frankly. So I can't really say I have metrics to back that up. But yeah, so I don't have an answer for you. It certainly could be very different today, no doubt about that.
Great, thank you. In regards to the California Right Meds Collaborative, I know it mentioned that there was a stringent pharmacist vetting process. Can you provide us more information about what that vetting process looked like and what the expectation is of the pharmacists participating in the program?
Love that question.
Sorry, Steve. Jessica, if I could chime in real quick for your previous question on the well-being. Just really, really briefly. I think that's a really good question to focus on. And I think, hearing from members and friends and colleagues as well. So this is personal thoughts. I think that pharmacist burnout is really important to address, and so glad we're going to talk about it. And that's definitely one piece that the committee can consider how to tie in supporting pharmacist wellness to standard of care. And I think some of those things would be ensuring that one, there's adequate staffing levels to support that so that, additional tasks are not be placed upon pharmacists that are unreasonable. And also just from talking to colleagues, when they feel like they're being valued and that their education is being utilized, they're happy to do the work. It's when they're, it's when they're being restricted that they're not happy with that. And then third, would be the reimbursement model and being paid for it and all of that. But I think, first and foremost, thinking about how can we tie this to protecting the work environment to ensure that these services are appropriately staffed. And I can say, not going to speak for Steve, but I think within the CMMI program, all of the pharmacies who are involved have very mindfully thought about how do we staff this and operationalize this so that it doesn't sacrifice and overwork our current staff and current services.
And to that point, Richard, thanks for bringing it up. We found that having that technician provide support that you don't need a PharmD for resulted in a 50% increase in daily patient visit volume. So certainly I fully agree with what Richard just said. So in regards to your question, vetting pharmacies, it really starts with a health plan, right? They have hotspot geographies where they have patients that are high risk, they're high utilizers, and are having trouble with a chronic disease. They know where those areas are. We reach out to those areas in particular as much as we can and try to identify pharmacies that would be interested in joining the program. When we get some interest from pharmacies, we'll send them a very heavily vetted survey that goes through all the components of what we think are important to provide clinical services. You know, have you had some experience with clinical services? Do you have a waiting area? What services do you currently provide? Do you have any outcome metrics, things like that? They complete the survey, they get an on-site assessment with a combination of either the health plan staff goes or health plan staff and one of our team members goes together just to do a visual inspection of the location to see, you know, did they answer everything truthfully? And then ask some more questions just to confirm that this might be a good place for CalRightMed's CMM services. And the last piece is the health plan will take a look at any quality data they have to assess whether or not this pharmacy is a reasonable performer. And if they jump through those 4 hoops and they pass, then they are allowed to be part of the collaborative.
Great, thank you. I did have a question about health literacy. I know that was another measurement that was improved through the process. How was health literacy measured through the program?
I don't think we actually had anything beyond patient satisfaction surveys to assess at least their experience. And that was with a very standardized survey based on CAPS surveys, which you're probably familiar with, the standardized CAPS tool. So we were able to show at least that through that standardized tool, we were hitting patient satisfaction scores that exceeded Kaiser's, and Kaiser's are really high. So it's an indirect measure of literacy in that case. But to your point, that's the ABC, that's the A of CMM. If you can't get a patient to understand their disease state, get engaged, you're never going to get past that point. And so that's always the essential foundation of comprehensive medication management.
Perfect, thank you. I want to thank you, Richard Dank, for addressing some key points that can't be overlooked by the board. So you mentioned staffing levels and being incorporated into a standard of care model. And then I think another really important point is the reimbursement and payment for pharmacists. So I'm curious with these programs, how exactly the pharmacies and or the individual pharmacists were compensated for their participation.
So Dr. King may want to give a little more details, but the way we approached this initially was we looked at the cost of delivering care in that CMI program that I shared with you. We determined that for per patient, it was in the ballpark of $1,000 or so for completed care. And so that was then divided into a shared risk payment model, a value-based payment model, where part of the payment to the pharmacy were given fee for service for limited terms, say 5-6 visits, and then the other half of the payment would be withheld until the value-based metrics were met. And in the case of that diabetes population, it was A1C blood pressure and statin utilization.
Great, thank you. Let me see if I have any more questions. Okay, so moving on to the LA Care portion of it. I really appreciate you recognizing some of the limitations to a program like this in a chain setting and really leveraging the independent pharmacies and that cultural barrier that you're able to overcome in settings like that. So I've heard you refer a couple times to the standard of care model, and I'm curious, when you refer to that, Alex, are you looking for a separate standard of care model for independent pharmacies versus a chain setting, for example? I know a lot of the times we think of standard of care and we think community pharmacies, but there's so many striking differences between the two. So I just wanted some clarification there.
No, I think eventually a chain pharmacy will do the services. It's just that they have to have a business model for it, right? It just takes more training and more time. The great thing about an independent pharmacy is that they're in the community, so they have incentive to make their patients healthier. So it does take an initial investment, and and just how we're a corporation, they're a big company too, and to get a chain on board, it's going to take a little more time and convincing because their profit center comes from the prescription, filling the prescription. This is we do pay enough to make a profit, and that's one of my goals too, is to pay an independent pharmacy a living wage, right? So where they're profitable. But it is going to take a little more investment than than probably a chain wants to do initially. So I think once we have the standard of care, we grow this model where the independents can be profitable and are seeing a profit, that some of the chains will be involved in it. So I don't see any difference between both. And I hope the chains also participate eventually too, just because like even CVS has the mini clinics, but those are nurse practitioners. And those are a little bit different where the patient goes to see like almost like a PCP visit. So we're hoping that they, just like the chains expanded, the vaccination clinics, that they'll expand into this model also. So, but for me, because half my patients go to independent pharmacy, I saw that as like an immediate impact, right? I want to get in the community, get to the people that need the help the most, and those are independent pharmacies that are in the community that live within a mile of everyone that I need to get in contact with.
Great. Thank you all so much. This was really informative. There's a lot of good information, and I'm happy to see that there are programs out there and that we can really make a difference in our communities by leveraging pharmacists and also just collaboration. And I appreciate the perspective from the physicians as well, because I haven't heard much from that. So it's very informative. Thank you.
Just a quick note, we did actually have a chain that wanted to join CalRight Meds. Alex knows about this. We went through over a year of trying to get them on board. And at the end of the day, corporate wouldn't allow them. So it's not that we don't want chains, it's just we couldn't get permission.
Oh, interesting. Thank you.
But just want to confirm, Laura, did you have anything to say? I want to make sure we are not saying anything that's not appropriate or what.
No, if I was concerned about that, I would have raised it. Good afternoon, members and presenters and public. By the way, I'm Laura Friedman. I'm today's counsel. Your regular counsel, Eileen Smiley, wasn't available today, so you get me returning from the past. I used to joke about being a bad penny. I'll hold off, and then after the members ask their questions, I have a few ideas, but I don't want to interrupt your flow. So.
Thank you, Laura. Okay, Renee, go ahead. Renee, you're muted. I do this all the time. I tell you. So we're all here on the same boat, unmuting, not muting. Okay, go ahead.
It's been a technological struggle day. So, and that was the easiest one. Anyway, so sorry. Thank you everyone for this very thorough presentation and just the collaboration together. Lots of information, lots of good information. So I did have a question. I believe this would be maybe Stephen Chin, but whoever wants to answer. I think it was during the time of discussing, you touched on it just previously about pharmacies that were trained in the California Right Meds Collaborative. So they were vetted and trained, but you did mention that there were some failures. And so I'm wondering if maybe you can just elaborate about how a failure was defined. And then it's kind of a two-part question, because I'm wondering, it sounded like they were dropped, but have you looked at how they could be supported to be successful? Because in a more larger scale, standard of practice type situation, we want everyone to be successful. So anyway, so wondering if you can address those couple questions.
Yeah, it's a great question. What happened was the pharmacies that were eventually dropped typically were a little more ambitious, thinking that, I'm a solo pharmacist, but I can do this, right? I swear I can do it. And we let them give it a shot, right? And it turned out that they ended up just not having enough time. They started to rely on students, for example, to do much of the workup, which really is not what LA Care wants to pay for. And the way that we knew is we have a very granular continuous quality improvement process. What I mean by that is we have process metrics that are temporal. So we know that by the second or third visit, if there hasn't been an escalation in medication therapy for diabetes, for blood pressure, that there's a problem there. We know that if by the second visit, there hasn't been some change in asthma therapy for an out-of-control asthma patient, there's something wrong there. So we can see this real time practically and address them in our every 2-week CQI meetings. And we de-identify everybody. It's not like we're trying to embarrass anybody in front of their peers. We have follow-up conversations to find out, hey, what's going on? And when it becomes evident that they just don't have the really more time, it isn't knowledge. They have the knowledge. It's more the time dedicated to follow up with these patients diligently. Then our message has been, yeah, we appreciate your interest. We know you can do this. It's just you don't have quite the resources committed to it at the moment to make this work. So let's just put you on hold until we refine the program further, and perhaps you can join another date. So there's only been really, of all the 25 pharmacies we have now, probably 2 or 3 that we had to let go in that sense. But the majority have done very well. They're committed. They believe in this work. And as Jessica asked about burnout, this is what many of them look forward to. They tell us this is why we went to pharmacy school, to help our patients. And this is giving us the resources and support to do it and do it at a high level. So we're seeing satisfaction from much of our participants.
So for example, in that situation, I mean, I think early on in the presentation was showing that there's not very many rural pharmacies. And I would imagine that some of those pharmacies are very small, probably only have one pharmacist, and yet that would be exactly where it would be great to have them practicing and carrying out some of this. But it's almost like it's kind of a catch, right? How do they, how could that be? How could they kind of know how to support that level of involvement with patients or get that started? Or does any suggestions for that?
Well, interestingly, if there's one blessing of COVID, it's telehealth. So we launched the collaborative right when things were taken off, Thanksgiving of 2020, right? So here we are thinking neighborhood, local pharmacy, all of a sudden they can't come in. So because of our experience with that CMMI grant in telehealth, we already had a complete template on how to provide this care remotely. So all of our teams started telehealth. And eventually, as Dr. Kane can confirm, as we moved on in this collaborative and we were struggling with just what you said, those areas that were more rural and trying to get services, the telehealth became a great solution. So we have been able to successfully reach out to those places through telehealth means at this point. Definitely would love to have a local pharmacy or more local pharmacies involved. And I think we still are working with at least 1 or 2 in Antelope Valley, but the telehealth works very well.
Okay, thank you. That does sound like a good solution. And then on a completely different question, I know we talked a lot about pharmacists, but it sounds like some of the success was with using also what you had in the beginning, clinical pharmacy technician. So can you kind of explain that title and that training and exactly, what's the ratio there for those type of technicians?
Sure, and I'm going to credit Dr. Rita Shane for that label, since she's really been the pioneer of expanding roles of technicians. So what we did is, early on we knew that, and I've been in practice for 25 years. I know there's a lot I do in the primary care setting as a clinical pharmacist that I don't need my PharmD for. And what do I mean by that? Things like just contacting patients to solicit their involvement, reminder calls, check-in calls, simple yes/no things like that, rooming patients. I don't speak Spanish, so I'm not great at the translation part. Doing the follow-up appointments, things like that of that nature. We took all of those things and trained pharmacy techs to do them. Again, they're not interpreting anything. They're just providing function processes. Also managing patient assistance programs, if those are relevant for the patients we're serving, things like that. So those are the main pieces of what we train our techs to do. And again, the blessing, I think, is that many of the technicians are culturally and linguistically aligned with the patients we serve. And so they're just remarkable at building rapport with our patients very quickly without our training.
Okay, thank you. Yeah, thanks again for the presentation. I don't have any more questions at this time.
Thank you, Renee. Other member questions before I jump in? I'm just, so I have quite a few, so please bear with me. I'm just trying to focus on our committee's mandate, which is to try to answer the question. And so that's why, and please forgive me, I'm not trying to be interrogative. I'm not trying to be negative. I'm just really trying to kind of get to the bottom of what we need to figure out. So I feel confident. I'm sure everyone in this room or everyone on the board, no one disputes the added quality pharmacists are providing, obviously, and for patient outcomes. I kept saying this. I've said this multiple times. I say this everywhere I go, that one day I wish that this is the kind of model that pharmacists are involved everywhere, working in clinics and, working beyond. But so current law, it seems to me, allows this kind of thing to operate, obviously. So you guys are operating this program, wonderful program. So, and I'm genuinely asking this not to be questioning it. How are we going to make an improvement by having standard of care enforcement model would improve this kind of model? Like, what can standard of care actually make it better? Because we are already doing this, and I'm not trying to be cynical, as I said. So just how is standard of care going to make an impact broader in this kind of programs that we already have going on?
President O, and I think I just want to highlight something that I think it was Steve who said in his presentation. It's all about the barriers. Currently these programs with LA Care and CMMI are all happening through collaborative practice agreement, and to get those CPAs in place takes a lot of legwork, takes a lot of time, and that's often why you only see these programs in integrated health settings. And there's a very small number of independent pharmacies, some of which I work with because of our residency program, but there's not too many who have the resources and capability and connections to be able to have a physician to agree to have those collaborative practice agreements. And even if they do, it's with a specific provider office, right? In an integrated healthcare system, it covers the entire company. But if you're an independent pharmacy trying to have a CPA with your patient population, you're likely working with 10, 20, 30 different local primary care providers, and you have to get 30 individual agreements in place, and that's a lot of work, right? And so that disincentivizes those locations from participating. It creates a lot of extra barriers, and then it delays the care that the patients can receive. And I think both Alex and Steve talked about it. So by moving to a standard of care model, we would really be reducing those barriers to allow more locations to engage in these activities without having to go through the months of trying to communicate with the provider and trying to get these agreements signed with multiple people. And they would be able to apply these services right away to the patients that they serve. So I think ultimately it's reducing the barriers and reducing the delays.
Thank you, Dr. Dang. So obviously, ideally, we live in a perfect world. All pharmacies are equal. All pharmacists are equal. But that's not the case, as it was already discussed today. You will see in our subsequent meeting materials, we have a number of pharmacy license broken down by the ownership types, and half the pharmacies are chain pharmacies. And I know you guys are mainly, involved in independent pharmacies, but we as board, unfortunately or fortunately, actually neither, we have to consider all cases, all circumstances, discussing standard of care. How would we balance that, in your opinion? And again, I'm just genuinely asking, because we already have a very severe problems in pharmacies, mainly community pharmacies, in terms of staffing challenges and not having enough resources. How can we, if to me, standard of care is adding more work for the pharmacists in almost a way, I don't want to simplify it. So how can we make their work more complex? How can we balance that so that this does not negatively impact already a very chaotic situation that's going on? Like, we already have pretty complex situation we're dealing with pharmacists' working conditions. So I know, Dr. Chen, you're wanting to say something. So go ahead, and Dr. Dang, anything you want to say? Or anyone else, please speak.
This was a very important consideration that you're bringing up that we thought of when we launched this collaborative. The last thing we wanted to do was to put these high-risk, challenging patients into community pharmacies and say, find time to do this, right? So, so our design of this is, and Dr. King can confirm this, is we are moving towards getting a full panel size enrollment for every pharmacy. What does that mean? That means getting somewhere between 200 and 250 patients assigned to each pharmacy. You're probably thinking that's terrible, right? But the reason why is because with the value-based payment model that we have set up, that'll support a full-time pharmacist and a full-time technician. So you can hire somebody in that maybe has residency training, right? Maybe has additional skills where you don't have to really, prepare them or accelerate their preparation. They're ready to go, and they're fully dedicated to providing patient care services instead of having to pull pharmacists from within the pharmacy. I mean, that's at least the goal of what we have in mind here, so that we don't burn out our community pharmacists. And the other point I think is really important, right? I actually don't see a big divide, as big as maybe some people see, between retail chain drugstore pharmacies and independent pharmacies. And I say that because you're hearing it more and more today. The chains are investing in resources and expertise and in programs that are very much aligned with what we're doing here, right? I've heard many of the statements from folks at Walgreens, at CVS, other places. This is the direction they want to go into. They want to be involved in being an extension of the healthcare system, a place where patients can get services in the community that are high value, high impact. So I would not be surprised if the chains either join our collaborative or replicate many pieces of it. And I can say that because I've spoken to some top national leadership of these chains. That's exactly what they're thinking.
Yeah, and I'll add on too. I think the key is just what Dr. Chen said, more personnel, right? And so when we think about from a regulation standpoint, how does the board encourage stores to have more personnel? And I don't have the perfect answer. That might go to the staffing ratio requirements, correct? And if we're thinking about clinical services, does the committee believe it's feasible to implement some sort of ratio that is tied to the volume or number of services that might be provided? That could be an avenue to help address that and encourage that there's adequate staffing in those stores, especially in settings that are currently overworked. So I think the key is, encouraging those locations to add on the staff, and we're seeing some responsiveness in those independent pharmacies that Steve and Alex are working with, where they do hire on additional people because there is that revenue business case for that. And I think, how do we make that more universal? If you're not, one, the reimbursement piece will definitely help encourage more stores, but also from a regulatory standpoint, is there something that would encourage locations to have a minimum number of staff that would be considered safe to provide these standard of care services?
Yeah, well, we reimburse based on the profitability. I want these pharmacies to succeed. Like one of the main goals that, like as a LA Care director of pharmacy, is I don't want my independent pharmacies to shut down. We always talk about this PBM regulation, reimbursement. Guess what? This is what I do, the reimbursements. And I try to keep the reimbursements as reasonable as best I can, because there are laws for this. And I want these independent pharmacies to stay open so that I could have this outreach to the communities that I need to. So, when I set up this program, it's with the goal of they could sustain it, they could be profitable, and they want to join. And the chains will join once this is on board, because they'll make money off of it, right? And I don't mind paying more because of the ROI I'm getting. At the end of the day, making people healthy saves me money in the long run. So I'll pay to make people healthy. So let's, and the businesses will want to make a profit. So that's kind of the way I see it. And how this is set up, they're making a profit, and they're going to stay in business. And this is one of the ways where, as drug reimbursements go down, because that's just industry standard, I could funnel this money through this program to keep the independent pharmacies, to give them another profit center, another revenue stream. And I think that's what these pharmacies are interested in.
Thank you. Thank you for the questions and answers. I'm gonna let Jesse jump in. Go ahead, Jesse.
Thank you. I just wanted to chime in real quick. I kind of had a follow-up question to what we were just discussing. Can you remind us how many patients were under each pharmacist's care for each of these programs?
Are you speaking of CMMI or CalRightMed, sorry.
Yeah, I guess for both of them.
So for the CMMI program, it was anywhere from 350 patients per pharmacy team, and that was a pharmacist and technician, to 700. The 700 is not sustainable. They were working 12-hour days, I'll tell you that. So we know that the right sweet spot is somewhere around 350 plus or minus in that range. Yeah, and again, keep in mind also that's an integrated health system. So we know that in a community pharmacy, the number is probably not going to be that high, right? So in the CalRightMeds program, the pharmacy that has the highest enrollment currently today is close to 100. So we're not, quite at that point of full enrollment size, but 100 is the highest at this point.
And was the program in addition to their daily workload, or were they just doing this collaborative agreement during the program's duration?
You're referring to CalRightMeds, I'm assuming.
I guess it was CMMI, since it was such a high volume of patients that they had per each pharmacy team.
Okay. Yeah, they were fully dedicated only to clinical services. In fact, Altimed never had clinical pharmacists before the CMMI program came in.
Okay. I will just say the sound of 200 to 250 patients to each pharmacy is alarming for me. I know someone had mentioned that pharmacists want to expand their role. In my experience, and a lot of the pharmacists that I speak to in chain settings across California, a lot of pharmacists just feel like they can't do any more. And that's just now. I can't imagine how anyone would be able to manage 200 to 250 patients. And I know, that's in theory to support one full-time pharmacist and one full-time technician who are dedicated to that. My worry is that specifically in a chain setting, that would be added on top of workflow. Granted, standard of care, you can make you have the discretion to decide, what should be done. But yeah, I think that for me that number is very alarming for chain pharmacies who are already at their wits' end with their workload.
Yeah, I know Richard's going to comment, but I'll just quickly say that to your point, this is why we wanted to make sure that it was a volume that would sustain that additional personnel so that it wouldn't be an added workload. But you do need the space and workflow that would accommodate. You're absolutely correct about that. Richard, go ahead. You're going to comment on something.
I just want to kind of give some added information. To be clear, this isn't 250 patients you're expected to see in a day. This is 250 patients you're expected to see throughout the duration of the program, spread out across many weeks and many months. And when we're talking about panel sizes in an integrated healthcare system, for point of comparison, a PCP might have 1,000, 2,000, 3,000 panel size, right? And so for the CMMI portion, when Steve was working, they had, 350, maybe higher in the pharmacist panel size. So I think for the community independent retail pharmacist setting, definitely be much, much lower than that. And, the point about being overworked, that's absolutely what needs to be addressed as a part of this. So, the idea would be you would have your regular pharmacy staff doing your current dispensing operations. That's the foundation of a community pharmacy, retail or independent. Then you would add on additional staff to be able to address the patient visits. And that's what we're referring to when we're saying to be able to hire to support an additional pharmacist. So then in that model, it could be that there's one pharmacist and 2 technicians using your standard ratio that we have currently to support the ongoing dispensing activities, and then an additional 1 pharmacist, 1 technician to support the clinical activities that are coming in. And when you look at a daily visit, so we'll use the USC Pharmacies as an example, we schedule out our visits every 30 minutes. So at most in an 8-hour shift, that 1 clinical pharmacist is seeing 16 patients a day, right? And so I just want to put that into perspective as to the numbers that we're talking about. Definitely 250 in one day or in 1 week. I agree with you, absolutely overwhelming. But I think we're talking about 250 for the duration of the program, and then it's up to that pharmacy team to spread out those patients in the best way possible and follow up with them during that duration in a manner that's consistent with, that consistent with their workload and their work schedule. And then the other piece that maybe the committee wants to think about is, who's responsible for setting these schedules? Is it the company or is it the pharmacist, right? And so I think there needs to be some balance between that, because I agree with Jessica. You don't want to have a company come down and say, you're going to have to do 200 visits a day. Well, if the pharmacist doesn't believe that that's feasible, they need to be able to set their clinic calendar, which is what we have at USC for our pharmacies. So just lots of really great questions. I just wanted to add in that added information as a part of that conversation.
And thanks, Richard. To clarify, 16 visits a day can easily support a panel size of 200, 250. I guarantee you that. We know that from our experience.
Thank you. That clarification helps a lot. So thank you for that thorough explanation. I guess as a follow-up, and I'm sorry I ended up taking it back to me, but I guess if somehow, patients drop off or they move and it falls below that 200 to 250 patient range, and then it's not really financially sustainable, I guess what happens next? Is this going to be the sort of thing where independent pharmacies are losing money by doing these programs, or even chain pharmacies, or that they they don't have the means to support this extra workload for employees?
Yeah,
we add people all the time. So we're the unmet need is so great that there is no 250 is not enough. That's my problem right now. I need more pharmacists and more pharmacies to open up. And the point of saturation, we're so not near that point of saturation where if I could, have way more. That's the reason why I'm pushing for this standard care model, because I just need more pharmacies. So that's how I'm seeing it as the data.
And our work has shown that in any given adult population of care, 15 to 20% need this service. So to Alex's point, there's not enough capacity for the needs of the patients that are out there.
Perfect. Thank you so much. I'll turn it back to Sung. Sorry for taking over.
Jesse, always great questions and comments. So let me, just for the sake of time, I think we're kind of running out of time. So sorry. Thanks for enduring us here. So one more thing. I know there's a lot more questions. I would probably take 8 hours if I could, but I gotta, for the sake of time, move forward. About this clinical pharmacists, community pharmacists, retail pharmacists, pharmacists working in chain, pharmacists working in independent settings. And I am deeply concerned about the kind of unofficial, official disparities going on between the licensed kind of your practice setting of a pharmacist. And I think that the model you described, Dr. Dang, is a good model, but it does give me quite a concern about, a pharmacist that just works in dispensing and a pharmacist works in clinical kind of a setting, because I really want to remove that kind of disparities among pharmacists, because I think a community pharmacist who works in a community setting should easily be able to be trained to provide these kind of services, especially the services that you're mentioning. That is being done. So how do you propose that we reduce that barrier? I mean, I really don't want us standard of care creating a further division. I really would hate for that to happen. And so go ahead, Dr. Chen. Yeah.
Steve, I'll answer really first quickly. That's a really good point, President O. And I also want to highlight that in the example I gave about our USC pharmacy staffing model, that's actually just one of our pharmacies. Our other 2 campus pharmacies, they're hybrid. So we have pharmacists who are doing both the dispensing and clinical, but instead of having 1 and 1, now we'll schedule 2 or 3 pharmacists for the whole shift, and they share their work all together, right? So that's another model in which case the pharmacist isn't having delegated tasks like that. But even so, we're still expanding the ratio of personnel that we have staff for that shift. So I think both models can exist, and sorry to leave you with the impression I was only advocating for one, but that's a really great point.
Yeah, I love that point, because I agree with you 100%, President O. Same point that Richard just brought up. within our now over 24 pharmacies in Cal Right Meds, it's a mix. Some have a pharmacist dedicated, some have 3 pharmacists who share patient care responsibilities. Something really important to keep in mind, this rigorous training that I shared with you for the collaborative, it's applied to pharmacists that have completed residency and those that have not. And I can tell you the outcomes are the same. So we're able to show that pharmacists without the clinical training that go through our program can achieve the results that are just as good as anyone that's had formal training.
And this is the reason why I got this program to the independent pharmacies, because these are working pharmacists that don't have specialized training. They didn't do residency. They don't have board certifications. You can look them. I have a billion board certificates. It doesn't matter. I don't want people to have to jump through hoops to be able to do this, because at the end of the day, if you go to pharmacy school, you learned everything that you can do here. There's no actual extra training that's required. So that's the one reason I actually agreed to this program, and that's one reason I'm reaching out to the independent pharmacies and to the pharmacists that work in that setting. So I don't see this as a division. I see this as an add-on value, because the training's there, so we just have to take advantage of it, and we're seeing it work.
Well, you guys in LA County are lucky to have the LA Care. Thank you, Dr. Kong, for supporting this kind of program. I think that this program, unfortunately, is impossible in San Diego County because we have the regional model where we have like 5-6 different HMOs, Medi-Cal. So hopefully you all can lobby the government to change that model, so we'll be able to provide this service.
We've been invited to join San Diego through Be There San Diego. So we're there next. I'm speaking to them next month.
Thank you, Dr. Chan. So sorry that this took so long. I'm sure we could go on longer, but for the sake of time, we do have to move forward. So before I open up for public comment, I just want to quickly go through, make sure members who didn't speak, Indira, Maria, if you have any questions or comments before we go for public comment. Okay, I see their heads nod. Okay, moderator, if you could please open up for public comment.
Would it be okay
Laura,
if I made a few
Laura,
comments before you go to public comment? And mostly what I want to give you is the benefit of just my years of experience in California in this world. And I understand that the committee is focused on the task that the legislature gave you, which is, does the standard of care enforcement model, is it feasible and appropriate for pharmacy? What I hear you talking about, and even when I hear those terms, I think I want to flag for the committee members that as you're dealing with that, you work on the terms of art. The Board of Pharmacy and in the pharmacy realm in California, you apply a standard of care right now that exists. That is a legal term of art, and it's the standard that is expected of all pharmacists when they're practicing, right? So I'm a little concerned because what I hear discussed is really what I would traditionally call a scope of practice discussion, and that's a very legitimate conversation. But I'm concerned about the blending of those two terms because you have standard of care already, and I think there could be some confusion created if you imply, or if the impression is that we're inserting that into this discussion. So I just want to be very thoughtful about that, and I feel like I want to flag it just so it doesn't come as a surprise, because I think I did search for that term. I couldn't find that standard of care enforcement model anywhere else in the Business and Professions Code. But I do think that it's important for the committee members to have that in mind so that when you're working on that report, that you can clarify what it is you're talking about, and just it so that when you review what you do, whether it is looking at each of the provisions that are in the Practice Act or the regulations and evaluating whether or not those should continue, that's a more specific task, right? That's not necessarily a standard of care. It's reviewing your laws to see if you want them to be less specific, which is kind of what I heard the initial conversation. In other words, take some of the prescriptive requirements out of the law so that you have a more general piece. And that's pros and cons, but I wouldn't call that necessarily a standard of care. In my mind, like I said, that scope of practice and just weighing and balancing how much detail is in the law. So I wanted to offer that because hopefully as you move forward to be consistent with other healthcare services in California and other DCA boards, pharmacy absolutely already has a standard of care. It's just that some is more specific and some isn't. So
Thank you, Laura. Appreciate it.
Sure.
All right. With that, moderator, if you could go for public comments.
This is the moderator. The Q&A is now open. The instructions are on the screen for your reference. Members of the public, if you would like to participate, click on the question mark inside of a square, which is typically located bottom right corner of your WebEx screen. And in the text field that appears, type in comment or I would like to make a comment, and make sure you send that to all panelists. If you prefer, you can raise your hand by hovering the cursor over your name, and an outline of a hand will appear. If you click on that, it will raise your hand. And if you called in, you can raise your hand by pressing *3. So we have two individuals. First one, Daniel Robinson. I will send a request to mute your microphone in just a moment. There you go.
I thought that was an excellent presentation by all parties, so I thank you very much for that. I am curious about standard of care being practiced currently in pharmacy, because there's no place in Chapter 9 where standard of care is mentioned. You won't find those words at any point, so I'm a little confused about that. Remember, the reason that we're interested in standard of care is that we're trying to create a regulatory environment that supports pharmacists as healthcare providers. And that's one thing that our laws don't currently do very effectively. There's been a lot of discussion about standard of care and where the care is being provided. But honestly, our discussion should be focused on standard of care as it applies to the pharmacist, the licensed pharmacist, wherever that pharmacist is working. When you think about the framework for deciding what a pharmacist might or might not do, number one, they need to be trained and qualified for whatever it is they're doing. They need to be doing things that are based on evidence-based healthcare practice. And they need to be doing it in a practice setting that supports policies and procedures that are supporting those activities. So if you go to your primary care physician and that primary care physician is not going to be able to provide all healthcare services at that clinic. Some things will be better provided someplace else. Minor surgical procedures might be done elsewhere. So this is no different than in medicine, where you only do what, number one, you're qualified to do, and that you're in a setting that supports those activities. So if there is a chain pharmacy, for example, that doesn't support those activities, well, the pharmacist won't be doing that activity. But if you're in a setting that does support it, absolutely, we need to provide, I believe, a standard of care approach and regulatory environment. So with that, I thank you very much.
This is the moderator. Next individual, I have Ellie Lanu. I'm going to submit a request to unmute your microphone.
Thank you. Presenters. I had a question for Dr. Dang. As an advanced pharmacist or advanced practice pharmacist yourself, I'm curious how standard of care would impact section 4052.6 that you outlined in your slides.
Yeah, that's a really great question. I think that provision for advanced practice pharmacists actually is a really good example of the use of standard of care. As of January 2022, we know that there were a few legislative changes to that text around the scope for advanced practice pharmacists that essentially state that, APPs can initiate, adjust, modify, and discontinue drug therapy in coordination with the physician, thus removing collab practice agreement or protocol references. And so for APPs, that's basically a good example of how standard of care can be applied. And now I think we're talking about whether that might be feasible or reasonable to the RPH licensee type.
Next individual identified as Keith Yoshizuka. I apologize if I mispronounced your name. I'm going to submit a request to unmute your microphone. I see 2 logins for you, so let me know if it's the correct one.
I had done it correctly the first time. Shoot, now we got to echo. Anyway, Keith Yoshizuka, California Society of Health System Pharmacists, wanted to go on record as supporting the concept. California has a long history of pharmacists being involved, looking at Kaiser Permanente, Veterans Administration, and I think migration to this model would go a long way, because through my experiences in waiting for responses for medication therapy modification from the prescriber, some patients don't have the time to wait. They just end up leaving without having the adjustment made. So thank you.
This is the moderator. No further requests have been submitted. Would you like me to close the Q&A?
Thank you everyone for joining. I really, really appreciate your time. I also do hope and ask all of you to monitor our workforce ad hoc committee as well as our regular board meeting that hopefully will give you an idea of why this issue is such a challenging issue for all of us to contemplate and deal with. So please keep up with our all-day board activities, and thank you all the presenters. Really appreciate your time for your wonderful participation. Thank you guys, appreciate it. Okay, so we're ready to move on to the next agenda item. Next agenda item 5, discussion and consideration of statistics, including information on pharmacy ownership and investigation timeframes. The meeting materials include data requested by the committee at its last meeting. Do you have any questions or comments, members? Okay, I just want to note that for the record, it is quite apparent as of at least right now, our investigation time, I'm sure there are a lot of factors involved, but our investigation time versus medical board seem to be shorter. But obviously it's not apples and oranges, as we said that 1,000 times in our meeting here. So very difficult issue to contemplate. So we're going to move to public comment.
This is the moderator. I am opening up the Q&A. It is now open. Members of the public, if you would like to participate in this agenda item, the instructions are on the screen. Simply click the question mark inside of a square, type comment in the text field, send it to all panelists. You can also raise your hand by hovering your cursor over your name, clicking on the hand outline. If you called in, you can press *3 to raise your hand. No requests. Would you like me to close the Q&A feature?
Yes, please. Thank you, moderator. Okay, moving on to the next agenda, item 6, discussion and consideration development of pharmacy survey related to current practice and possible movement to standard of care. I am concerned that the committee has generally not received input from regular pharmacists, a key stakeholder in this discussion. I support development and release of a survey to solicit feedback from pharmacists on current issues as suggested in the meeting materials. I believe this information is necessary as we complete a comprehensive review of the issue. Further, this information could assist in developing a recommendation and demonstrate the efforts undertaken by the committee and board to solicit feedback from stakeholders. I believe it is important to note that the survey would not be intended for formal research, but rather similar to a short questionnaire as a means to provide an additional method to obtain input in the process. If members agree with the questions, I do also welcome members to make any corrections or changes or recommendations to the questions proposed. But if the members agree with this approach in general, the topics and responses to questions will be helpful. I can work with staff to finalize the survey in consultation with DCA experts and release the survey ideally in sufficient time to allow the committee to receive the results by the next standard of care meeting, which is scheduled for October 25th. I think that, so if any members, any comments or questions or concerns about the survey questions or the general premise of what we're trying to do, please raise your hand. I see Maria's hand raised and Nicole, I see yours hand raised. So we'll go to Maria first. Go ahead, Maria.
Thank you. I do have a question about information that may come back to us that is identifiable as to either the pharmacy, workplace, or even the pharmacist. How can we prevent this from being a part of the survey? Because there are some really delicate questions in here that if it comes to our attention that we would have to respond to. And I'm just curious about Laura, if she has any comments about that too. If information comes to us that would need further investigation, if it becomes that we have some identifiable information, are we legally liable to open investigations on all of the issues?
Great question, great point. And before I go to Laura and Ann, I just want to, I think we had a similar kind of questions for our workforce survey questions. So I feel pretty comfortable, but let's listen to Ann and Laura.
Ann, do you want to go first? Do you want me to? Okay, I see you nodding. Hi, Maria. Good to see you again. I believe that surveys can be structured how you want. So you'll get generic information. Typically, you won't get names unless they provide them. But if there is information that's provided, then I think that it is handled like any other information that's provided to the board. If it's through Ask an Inspector, if it's through a telephone call about a license, if something comes up to the board, then it can be elevated to determine whether or not additional legwork needs to be put into it or a complaint needs to be open. That's my general response. I don't know if Ann wants to add anything further beyond that.
We intend to use the same method that we did when we did the workforce survey, where it is anonymous. And if it helps people feel a little bit more comfortable, we can ask them to refrain from using the name of their employer if that's of concern.
Go ahead, Maria.
A follow-up then, because we do have comments from members of the public that they are either uncertain on how to report issues from their employer, or feel perhaps that it's not safe for them to report information. Could that be something that's included in the survey? Is the method or the pathway to report information to the board that would not be included in the survey, but open to the current processes as a reminder? Just a thought.
I think that's a great idea. And if you think that that may work, we could probably have that as an opening statement to the survey release. But I'll defer that to Ann and Laura for feasibility, if that's actually appropriate or okay.
Yeah, I think so. I guess Yeah, I guess I'm feeling more inclined to put it at the end, but I think a general statement about it and a reminder, because I'm thinking if we do it at the end, we could maybe even include the link if someone wants to how to do it, direct them to our website, the appropriate link, perhaps. I don't know.
Well, hopefully before, so that they don't like say all the identifying information in the survey, and then at the end they're like, oh, oops, so we'll see. We'll figure that out. If the members are agreeable, we'll figure out the right way. Nicole, go ahead.
Wanted to flag if we intend this to be specifically about standard of care, I understand the questions are where they're getting at. Are we going to include some kind of a blurb about what standard of care means? Because I don't know that everybody is on the same page about what that means. And I don't know if all pharmacists are super familiar.
I feel like we are also not all on the same page about that either. So I think that may be a challenge. So I guess we could share some concept, but of some sort.
Yeah, I just think like some kind of a concept of
right. What it means.
Yeah.
In other professions.
Theoretically.
Yeah.
Yeah. Okay. Thanks.
Thank you, Nicole. Jesse?
Thank you. I agree with Nicole. I think some information or just a blurb about what standard of care is in theory would be nice. I think the survey is a great idea. My only suggestion would be for question 5 to maybe separate that into 2 separate questions. Believing, do you believe you have sufficient time to make patient-based decisions? And then do you believe you have the autonomy? That's my one note.
Okay, that's a great point. So are we all in agreement, and are we all agreeable that we release survey as Ann and I will work to refine these questions? Any suggestions, please share with us, but are we all in agreement? And the motion's not required per our council. So we could just work to release a survey, and hopefully the results will be gathered by the next meeting, which is scheduled for October 25th. Is that agreeable to all the members? Okay, for the record, I am seeing the nods, but I don't know if that's sufficient. But so I will just confirm with that I see every member nodding. So hopefully that's sufficient for the minutes to reflect. Okay, Jesse, you're good, right? Your hand's still raised. So okay, all right. So with that, I don't think that we have any further discussion for today. So this was, and we're gonna go for public comment before we move on to the next agenda item. So, moderator?
As the moderator, the Q&A is now open. The instructions are on the screen. If you would like to participate, click on the question mark inside of a square, type comment, send it to all panelists. You can raise your hand, hovering the cursor over your name and clicking on the outline of the hand, or *3 if you're calling in. I do have individual identified as Paige Talley. I'm gonna send a request to unmute your microphone.
California Council for the Advancement of Pharmacy. I just have one suggestion, and that would be that in the introduction of the survey, you include that the results will be reflected at the October 25th meeting, because human nature is to put things off. We all know that. And I think if they know that the results are necessary for the board, they'll more quickly respond. Thank you.
No further requests have been submitted. Would you like me to close the Q&A feature?
Yes, please. Thank you, moderator. Okay, so we're moving on to the next agenda item, future committee meeting dates. Our future committee meeting dates scheduled for October 25th, 2022. Hopefully we'll continue on with the survey results and also continue on with the policy questions we're contemplating continuing from the last meeting. So we'll have a lot more to talk about on the meeting on the 25th. Thank you everyone for all your participation, your hard work, and the time and commitment. And thank you to all the presenters for coming to the meeting today. The meeting is adjourned, and I will see all of you in about 52 minutes. So hopefully that'll get you some good rest. Bye, everyone.